Hey everyone, and welcome to This Explainer. Today, we're taking a really high-stakes journey through the endocrine surgeon's roadmap. We'll be navigating complex clinical scenarios where a single millimeter of tissue can literally mean the difference between a complete cure and a total crisis. Let's get started.
Okay, let's dive right into our roadmap for today. We'll be covering adrenal anatomy and function, managing adrenal pathology, understanding men's syndromes, and finally, thyroid hormones and pathology.
Starting with Section 1, Adrenal Anatomy and Function, also known as the retroperitoneal danger zone.
So let's kick things off with our first clinical mystery to test your anatomical reasoning. In the context of adrenal gland anatomy, which statement accurately outlines the venous drainage pathway of the right and left adrenal glands? Think about why a surgeon might sweat just a little bit more when operating on the right side compared to the left.
And this brilliantly illustrates exactly why the right side is so terrifying for surgeons. The right adrenal vein is incredibly short, practically non-existent, and it drains directly into the posterolateral inferior vena cava, or IVC. Dissecting this requires immense skill because the risk of severe, catastrophic hemorrhage from the IVC is just massive. On the flip side, the left adrenal vein gives the surgeon a bit more breathing room. It's longer, it runs inferiorly, and it empties into the left renal vein.
Moving from macroscopic surgical danger down to microscopic detail. Which anatomical layer of the adrenal cortex is correctly paired with its primary hormone product? You know, the adrenal gland isn't just a uniform blob of tissue, it's actually a highly specialized layered hormone factory.
You can lock this into your memory using a classic medical mnemonic. GFR equals salt, sugar, sex. Let's walk through it from the outside in. The outermost layer, the zona glomerulosa, produces mineralocorticoids like aldosterone, that's your salt. The middle layer, the zona fasciculata, produces glucocorticoids like cortisols, so your sugar. And the innermost layer of the cortex, the zona reticularis, produces androgens, your sex steroids. It really is a perfect architectural map of adrenal function.
All right, Section 2, Managing Adrenal Pathology, High-Stakes Interventions.
Imagine you're managing a patient who has a suspicious, atypical adrenal mass. Naturally, you might be tempted to order a fine needle biopsy to see exactly what you're dealing with, right? But hold on a second. Before an FNA biopsy can ever be safely considered, what specific clinical entity must absolutely be ruled out biochemically?
So the crucial point here is that this is an absolute non-negotiable rule. Needle biopsy of a pheochromocytoma, which is an adrenaline-secreting tumor, is strictly contraindicated. If a needle mechanically traumatizes it, it triggers a massive release of stored catecholamines directly into the systemic circulation. This drives the patient into an instant, life-threatening, hypertensive crisis that can easily lead to a stroke or fatal arrhythmia. You absolutely have to screen for it biochemically first.
Let's look at another scenario and see how this builds. What is the preferred first-line management for a 28-year-old who presents with primary hyperaldosteronism, but their scan shows bilateral diffuse adrenal enlargement, rather than just a solitary unilateral adenoma?
Well, the answer here is entirely medical, not surgical. Unlike a unilateral adenoma, you simply cannot cure bilateral hyperplasia by cutting it out. Removing both adrenal glands would completely strip the patient of their natural corticosteroids, causing permanent severe Addisonian adrenal insufficiency. Instead, the life-saving standard of care here relies entirely on competitive receptor antagonists like spironolactone or eplerenone.
Moving on to Section 3. Understanding men's syndromes, the genetic web.
Here's a classic pattern recognition challenge for you. Which inherited familial syndrome characteristically links primary hyperparathyroidism, anterior pituitary tumors, and pancreatic neuroendocrine tumors?
It's multiple endocrine neoplasia type 1, also known as MEN1. Driven by a germline mutation in the MEN1 tumor suppressor gene, it neatly presents as the unforgettable 3 Ps. Parathyroid hyperplasia, pancreatic neuroendocrine tumors like gastrinomas, and pituitary adenomas. If you see this specific triad of tumors, you are looking squarely at MEN1. Now, what about the MEN type 2 family? Both MEN2A and MEN2B feature a deadly combination of medullary thyroid carcinoma and pheochromocytoma. But how do we actually distinguish MEN2B from MEN2A in a clinical presentation based on visual and systemic features?
The visual and clinical contrast is actually pretty striking. MEN2A frequently features primary hyperparathyroidism,
We see that in about 20 to 30% of cases. MEN2B, however, is characterized by a complete absence of hyperparathyroidism. Instead, patients with this highly aggressive 2B variant present with some very unique phenotypic features: a marfanoid habitus, meaning they're tall with unusually long limbs, and visible mucosal neuromas clustered on the tongue, lips, and eyelids.
Okay, this leads us to a really critical sequencing dilemma. Imagine you've just diagnosed an MEN2A patient. They have an active pheochromocytoma and an early-stage medullary thyroid carcinoma, so two serious tumors requiring surgery. What is the absolute mandatory sequence of operative interventions here? Which one must the surgeon remove first?
This is an inviolable rule of endocrine surgery. Step 1, you must always resect the pheochromocytoma first. Step 2, only then can you perform the total thyroidectomy. Why? Well, because undergoing a major neck dissection with an active, unresected pheo exposes the patient to an extreme risk of a fatal, intraoperative hypertensive crisis during anesthesia induction or surgical positioning. You simply must secure the catecholamine source first. No exceptions.
And finally, Section 4, Thyroid Hormones and Pathology, the Metabolic Engine.
All right, let's look at a fascinating cytopathology mystery. A 45-year-old patient undergoes an FNA of a right thyroid nodule. The pathology report comes back as a Bethesda Category 4, Hürthle cell neoplasm. What is the standard initial surgical step to handle this specific finding?
The required standard step here is the diagnostic right thyroid lobectomy. The reason is purely structural. You see, needle cytology alone simply cannot differentiate a benign Hürthle cell adenoma from a malignant Hürthle cell carcinoma. Diagnosis of malignancy strictly depends on looking at the physical tissue capsule to identify capsular or vascular invasion. You actually have to remove the lobe to get that formal surgical specimen.
Now, what's really interesting about this next question is that it fundamentally challenges what the thyroid gland actually produces versus what our body functionally uses. Which thyroid hormone is biologically active at a cellular level within our target tissues, and how is the vast majority of it actually generated?
We often think the thyroid gland does all the heavy lifting, right? Well, while it predominantly secretes thyroxine, or T4, that actually acts largely as a prohormone. The true metabolic engine is triiodothyronine, or T3. And here is the crazy twist. Roughly 80% of your circulating active T3 isn't even generated inside the thyroid gland. It's created outside the thyroid via the peripheral deiodination of T4 in peripheral tissues like the liver and kidneys.
Which leaves us with a highly provocative thought. If your liver or kidneys are compromised, does your metabolism crash right along with them? It really changes how you view the body's entire metabolic web. Keep questioning, keep learning, and I'll see you on the next explainer.